In the coming months, I want to issue a multi-year tariff for the 4 years covering the remainder of this spending review period and all of the next. It will begin the process of showing how we realise David Nicholson's challenge of finding £15 to £20 billion worth of savings over the next spending review period. The multi-year tariff will set out the scale of the efficiency and productivity challenge year on year, building up over time with the most demanding savings coming later. When set against the overall spending for the NHS, where my priority will be to protect and enhance frontline services, it will give the NHS certainty and a longer run at the challenge. It also gives us time to make what can still feel a counter-intuitive argument to some in the service, that quality and prevention are the best routes to financial sustainability. I am confident that we can win hearts and minds. For instance, winning the war on hospital infections through higher quality services has saved the NHS up to £260 million a year. So, quality cuts costs is more than a soundbite. In healthcare, it also happens to be true. We won't dictate to people how to make these savings. These decisions are better made on the ground. But by giving NHS organisations time to plan, we hope to avoid knee-jerk measures that can destabilise a local health economy. Going forward, I want to see patient satisfaction measured service by service in each hospital and published on a regular basis. By lifting the focus on this, it will encourage the system to concentrate more on how things look through the patient's eyes. Currently, there is the potential for a disconnect between what the system is measuring and prioritising and what matters most to the public. A hospital could appear to be doing well, ticking all the right boxes, but not good enough in the eyes of its local public on things that weren't measures: dignity, cleanliness, how they were spoken to, and yes, car parking. At the moment, there is no real incentive to do this. If a patient is being treated for 2 separate conditions in the same hospital, the service they get can be radically different in each. This is not acceptable. Making this information readily available on NHS Choices will empower patients, helping them to make meaningful comparisons and informed choices about where they receive their care. It will also put commissioners on the spot, allowing people to ask awkward questions if they are tolerating inadequate services. But to create the bite on all-round quality that we need, it's got to be about more than shining a spotlight. I want to see payment linked to levels of patient satisfaction through a powerful new financial framework that rewards people-centred service and care. At the moment, quality is only faintly recognised in the tariff. In the future, we'll progressively link a much bigger proportion of a trust's income to quality and, importantly, levels of patient satisfaction. This is a big culture change for the NHS, which has traditionally been paid by volume. But my judgment is that the service and its staff are ready to make this change. With quality at its core, I think the NHS can finally move beyond the polarising debates of the last decade over private or public service provision. And let me begin where I start in this debate, and that is that the NHS is our preferred provider. But it is the important job of the Commissioner to test whether these services provide best value and genuine quality. Where a provider is not delivering quality, and the new accountability information will more readily demonstrate that, we will set out a clearer process that will provide an opportunity for existing providers to improve before opening up to new potential providers. This is fair to all, as it means everyone knows where they stand, and services stand or fall on the quality they provide. Too often, people's choice of GP practice is unnecessarily limited by practice boundaries. So with the profession, I want to open up real choice in primary care. Within the next 12 months, I want to abolish practice boundaries for patients to allow people to register with the surgery of their choice. That may mean a practice near work or in the local neighbourhood, from which they are currently excluded by dint of their postcode. But it means that their practice is based on their own needs, not by lines on a map or what is easiest for PCTs. We will work with stakeholders in the profession to make this vital change for patients and ensure that crucial services for those most in need, such as home visits, are protected.